and at the same time editors. We had also highlighted that all media houses should be invited. So you are aware that we generally run the ministerial briefing sessions where you interact with the ministers, permanent secretaries, and other chief executive officers to update you in terms of what is taking place, in terms of the achievements, in terms of highlighting areas that might need clarification, as we have generated a platform of openness and transparency brought about by the leadership of President E.D. Mnangagwa. So in addition to this press session, you also have a quarterly presidential interactive session where on a quarterly basis you'll be able to interact with His Excellency President E.D. Mnangagwa. But for today, we have this government meets with the media to ask any questions that you might be interested in related to water and sanitation, related to cholera issues, also related to the interventions that the central government has been in a position to implement since we have been having a lot of challenges from the city councils and in particular Harare Metropolitan province, which has a lot of deficiencies in terms of ensuring that we have a safe, clean environment. So the central government, under the leadership of President E.D. Mnangagwa, has managed to implement a number of measures in order to ensure that we have a practical, achievable solid waste management plan under Ministry of Environment, and he has also appointed Honorable Dr. Anxious Jongwe Masuka as a committee chair in charge of the WASH sector, focusing also on Harare Metropolitan Province. And we also have the Minister of Health and Child Care, Dr. Mumbeshora, also to highlight and clarify issues related to cholera and what central government is also involved in order to arrest some of the challenges that we currently have. But all this, as I've indicated, that the background is the failure by the city fathers, the failure by the city councils to be able to play a very important role in the management of affairs in the city of Harare. But also Dr. Masuka will highlight other interventions in other cities. We also have directors from other ministries who also support what the committee chair, Dr. Masuka. So I'll start with Dr. Masuka. Dr. Masuka, over to you.
Thank you, Honorable Minister. For the state, we appreciate your presence and the role that you play in communicating accurately what the central government is doing, especially in a critical phase such as this.
How dare you, Mark?
Well, thank you very much. I will give a brief overview of the water, sanitation, and hygiene sector in my capacity as chair of the Interministerial Committee on WASH. You recall that access to water and sanitation are constitutional rights as enshrined in Section 77 and 73 of our Constitution. And the President has eloquently declared his vision for Zimbabwe to become a prosperous and empowered African society, leaving no one and no place behind. And it is in this vein that a very elaborate structure has been put in place to address WASH issues. There are 5-6 ministries involved: the Ministry of Health and Child Care, the Ministry of National Housing and Social Amenities, the Ministry of Local Government and Public Works, the Ministry of Primary and Secondary Education, the Ministry of Finance, and the Ministry of Lands, Agriculture, Fisheries, Water, and Rural Development, also the Ministry now of Environment, Tourism and Climate. So this WASH sector is responsible for the coordination of all government activities in the water, sanitation and hygiene sector. We have the purposes of implementation and working party of permanent secretaries and groups and their subcommittees. We have a subcommittee that focuses on urban WASH issues. We have a subcommittee that focuses on rural WASH issues. We have a subcommittee that focuses on WASH in health. We have a subcommittee that focuses on WASH in education, which is why we have seen that we've been able to open schools without any issues. These are all task-oriented committees, subcommittees. We also have one that we mobilize when we have emergencies, such as the one that was mobilized when we had the cholera outbreak. Under the 21 or so working groups that the ministry has, we have now a WASH sector working group that also meets quarterly and involves all the 92 local authorities and interested stakeholders. So if you wanted to tune in to that meeting, you'll be given a link by the acting director of WASH, Shiruguru there. He can give you that link. A meeting will be held shortly. So the Secretariat of the National WASH Committee is the Department of Water, Sanitation, Hygiene Coordination. And this is resident in the Ministry of Land, Agriculture, Fisheries, Water and Rural Development. So outside these interactions that we are having, if you wish to get any clarification on any aspect relating to WASH, let's let Shiruru can stand up so that they can see you. That's the acting director, National WASH Coordination, reporting to the Chief Director, Water Resources Development, Irrigation, and WASH, Chief Director, Engineer Mutazo. So those two are the culprits. So according to the Water Act and Zimbabwe Act, we have the regulatory functions relating to water. Some of them still with Zimbabwe. You will be aware that we are currently reviewing both the Water and Zimbabwe Act to ensure that there is a separation of responsibilities and powers, that all the regulatory functions will now come to the Department of WASH Coordination. In that vein, we are also going to have a provincial structure. Currently, they are only represented at the head office, and this coordination mechanism for WASH, which goes to the local level, is actually done through other government agencies, RITA, and the rest of them. But just to indicate that the rainy season is upon us, we've seen a very substantial improvement in inflows into the major dams. We are currently at 81.7% full across the provinces, compared to about 63%, which would be normal for this season, although there will be variations from catchment to catchment. The Mzingwane catchment being the worst affected. Much North and Midlands are the provinces that have the lowest inflows at this stage, but we still expect that they'll be able to get additional inflows. Once we have these inflows, we monitor on a daily basis 32 urban councils' water supply situation. And if you want to get any update, you can get these updates from the Department of WASH Coordination. There are quite a few dams that have filled and are spilling, which is good news. But the focus for 2024 in terms of urban WASH on a mega scale for central government are the two metropoles, Harare and Bulawayo. And in particular, Harare, complement the efforts by the city of Harare to provide safe water and sanitation and hygiene to its residents. The president directed that we assist them by seconding a technical committee, and that technical committee is chaired by Professor Makurira of the University of Zimbabwe. We gave them a 100-day mandate. We extended that mandate We wanted them to increase daily water supply to 520 megaliters a day. We are currently hovering around 300, 350 megaliters a day, and the government has availed resources to kickstart this process. 1.6 million US dollars has been disbursed for the purchase of critical chemicals by the city of Harare. An additional 13 million US dollars is being looked into by the Ministry of Finance, Economic Development and Investment Promotion so that Harare's water woes can be eliminated. We are also, in the context of Harare, looking at 2 additional water sources. You recall that the president launched the Chekaranwa Commission in Chekaranwa, and the pipeline that leads to Wenimbi Dam, just outside Marodia. We want to accelerate that project so that we can get water from Wenimbi to eventually flow into Arala, and then we'll be able to maximize the utilization of Prince Edward Works at 75, 78 megaliters a day, to be able to supply Chitungwiza municipality, whose requirement is about 70 megaliters a day. We are also looking at an aquifer that has been found in the Seki area, augmented that. Then downstream 2026, 2027, we expect Kuji Dam to come on stream, be able to supply an additional 200 megaliters a day, and the central government is building that dam, the conveyance pipeline, and also the treatment works to assist the city of Harare. And in the expanded the scope of works, we've seen that 80% of the raw water, of the treated water intake, eventually becomes wastewater. And we've seen that in the case of Harare, there's lots of pollution, and we have to use 16, 17 chemicals to clean the water and make Cholera before we can utilize it, simply because of the pollution that's taking place. Government is considering widening the scope of works to include wastewater management for some of the major projects that we are currently undertaking. You will hear stories about Dawendel and its ability to supply water. We currently have only 1 pump working at Dawendel out of 5, and we can't decommission that at this stage because we are using that water to dilute the polluted water in Cholera so that we use pure chemicals to be able to condense that water. I'll stop there for Harare, but for Bulawayo, yes, government now has availed another $7 billion for critical repairs that are required in Zimbabwe, and also for the purchase of other critical materials. We want the Epping Forest 20 megaliters per day generation capacity to be operating optimally at about 60 megaliters a day, and then will be 4 megaliters a day to the farming community. So there are interventions in Bulawayo to ensure that we can get to the 155 megaliters a day against their demand indication of 175 megaliters a day. Bulawayo city is far better than Harare in terms of managing its chemical supplies. They do have adequate supplies. In fact, their stock ordinarily lasts 3 months, whereas Harare generally has less than a month stock of chemicals. So these are the interventions that the government wants to see. There are discussions with the technical committee that we've appointed for Bulawayo, and that technical committee has presented its first report. We have said they should look at it in the context of the long-term supply for the city of Bulawayo, which, as you now know, depends on Baishangani. Baishangani, the lake is at 70% completion. The pipeline is 252 kilometers. We've done 139 kilometers of bush clearance and a bid for trenching. We've done a proof of principle for the laying of the pipes that are about 1.2 meters in diameter. At full capacity, we'll be able to conveyance from Lake Baishangani to Bulawayo 220 megaliters a day, and Bulawayo will have enough water to last the next 8 years. So that's the intervention by government at the urban wash sector. I wanted to raise Zinwa. Is anyone from Zinwa here? Zinwa, which is, as you know, a government entity, supplies water from its 534 treatment works across the country to various service centers in the smaller towns. What we want to see increasingly is that any urban local authority be capacitated to take over and run its own activities, such as happened in Bridge and also in Rwanda. Regarding the rural wash sector, there are many development partners over the decades that have put poles in rural communities with DDF, now RITA, also doing similarly. But we have never had a coordinated national approach which the President, Dr. E.D. Mnangagwa, put in place. So we now have Rural Development 8.0, whose one component is going to be life-changing for the many rural residents. This is drilling 35,000 boreholes in 35,000 villages. To date, 2,600 boreholes have been drilled across the provinces. We also, under the Schools in Wash program, are going to be drilling 10,000 boreholes in 10,000 schools to ensure that there is safe water and sanitation. And along that, in terms of empowering the youth, we are going to be establishing 2,400 centers throughout the provinces. In terms of communication and what you probably would like to do and get a link to see the progress that government is making in terms of provision of rural wash infrastructure, we have the rural wash information management system. It's now operational in 651 of 60 districts and in 7 out of 8 provinces. So you can see the elaborate the wash program where the water points are operational, where sanitation is available, where it is not available, and then you can interact accordingly. There's been an outbreak of cholera, and the Minister of Health and Childcare will be able to give you the latest statistics. The wash sector has responded by concentrating on drilling of boreholes, ensuring that the water is safe, and the Minister will be able to provide additional information. I highlighted earlier the existence of a wash in schools subcommittee, and this subcommittee has enabled the safe opening of schools, as you have noted, compared to other jurisdictions in Southern Africa. The washing health will be reported on. We have seen efforts to improve, and the Operation Tenesai Harare has been launched and will now be on a more nationwide basis. This is in addition to what the Second Republic did when he came into office to launch the national cleanup every first Friday of the month. And if we adhere to that, certainly the cleaner environment will eliminate some of these diseases that we now face. I would like to stop here in terms of just providing the very broad overview of how government coordinates activities in the wash sector, and to allow the Minister of Health and Childcare to come in and give you the cholera specific interventions. And after that, there are other questions I'll ask the senior officials from the various ministries to come in and just give very brief updates, including Ministry of Finance, Economic Development, Investment Promotion, to just indicate the resources that have been availed. But all this, in conclusion, is indicative of a government that is sensitive, that is desirous to establish a safe environment for citizens to thrive. Thank you, Chair.
Thank you, Dr. Masuta, for the elaborate statement in terms of what the government under the leadership of President E.D. Mnangagwa has been able to achieve. And this is part of the whole of government approach, where we coordinate all ministers to be able to meet with the media. So for now, I'll hand over to Dr. Mombeshora, so that you can also give a statement. And thereafter, if there are any additionals from the other senior government officials, then the media can then be in a position to clarify the issues that the respective ministers have been able to issue statements regarding WASH, cholera, the environment, and the financial interventions that the government has been able to achieve. Dr. Mondocho.
Thank you. I don't know whether you want to move your.
Let me move. Yes, sure.
Hold the phone. Put it on. Good morning, everybody. Let me start by thanking the chairman for WASH program who has given us a very detailed report. Thank you, Honorable Masuka. I'm going to talk more on the cholera side, which is my responsibility. And I want to urge you, reporters, please to listen carefully and get the correct information. We've had challenges of people making wrong reports, even at some international fora, where there have been claims that in Africa, only Zambia and Zimbabwe cholera cases, and that we've got over 37 countries in Africa that are having cholera. So it's throughout Africa, it's not only in Zimbabwe and Zambia. Having said that, I'll give you the cholera situation as of 23rd of January 2024, this year. Our cumulative suspected cases are now 20,121. And I want to emphasize that we are talking of figures that have been recorded since the beginning of this cholera outbreak in February last year. That is February 2023. So these figures are covering a period of almost 12 months. They are just about a month to end of February. And I also want you to note that I've said suspected cases, because we are now treating any diarrheal case as cholera for management purposes, so that we don't delay managing and lose lives. Otherwise, we take time trying to make a diagnosis, taking specimens to the lab to say, let's confirm, and we lose lives. As a result of our intervention of taking every diarrhea case as a cholera, we've managed to have a very low case fatality rate compared to other countries in Africa. Our case fatality rate at the moment stands at 1.8% of 100,000, whereas in other countries it's much, much higher than that. And WHO accepts a case fatality rate of 1% and less. It means our management cases is quite good, despite having all these diarrheal cases. Again, when it comes to deaths, confirmed and suspected altogether, they are coming to 447 cases since February last year. And confirmed are those that we have had specimens sent to the lab and confirmed to say it's cholera. But most of our cases are suspected, so they will not have been confirmed. In the last 24 hours, we had 6 deaths. And I think that is quite a lot. Any death is not acceptable. In care, that is those who are admitted in our cholera treatment centers and districts of the infectious disease hospital, there are 232 throughout the country. And at the moment, 60 districts in Zimbabwe have been affected with various degrees. Some have got 1 case, some have got hundreds of cases. That's the difference. But as long as we have had a case in any district, we record that we have got a case Hotspots most affected are in Harare, Chitungwiza, Buera, Gutu, Chiredzi, Mazoe, and Mbire. These are our hotspots. Cholera treatment centers countrywide that we have established are now 153, with Masvingo province having 56 on its own, Manicaland 54. Harare has 4 built cholera treatment centers, and also business of infectious disease hospital has been designated for treatment of cholera. Other infectious disease cases that were managed at British are now being dealt with at Wilkin. So we have left British specifically for cholera cases. We have 949 cholera beds available in Zimbabwe, and we have set up 33 oral rehydration points throughout the country. Most of them are in the rural areas. The determinants of cholera outbreaks in Zimbabwe are centered on safe water provision, which is intermittent and not adequate, both urban and rural. Sanitation coverages which are low, best sewer pipes in urban areas, refuse collection which is intermittent, and more recently climate change coupled with flooding and drought. The recent surges around festive season were caused by gatherings, religious or otherwise, attendances to funerals, as well as movement in artisanal mining areas. To mitigate against the ongoing cholera outbreak now affecting 60 districts, my ministry duly activated the incident management system and appointed an incident manager. And I would want you to know the incident manager sitting right there, Dr. Piri, stand up so that it's he is the point person and coordinates all cholera activities in all provinces. And he has got the data on his fingertips. He's the man to ask for all the specifics and what is happening on a daily basis, because he gets the data before he briefs me. So you will have the information that you all require. We also have our public relations department, and this time Jiri, can you stand up so that we can see? I know most of you have got challenges getting to me because I always keep my phone on silent, and when I'm in meetings, I don't answer calls. So he is the man to talk about information, all information you need from the Minister of Health, Mr. Mchi. Having appointed him, he is supported by response pillars of WASH, surveillance, laboratory, case management, and infection prevention and control, risk communication and community engagement, logistics, supplies, and finance. These pillars are working every day to respond to the outbreak. And this is replicated at sub-national levels, where we have the deployment of the national and sub-national rapid response teams. So this coverage goes down to the what everywhere to get information on a daily basis. We are continuously setting up cholera treatment centers where these cases are being reported and treat the cases from these cholera treatment centers. There are 153 active cholera treatment centers throughout the country to accommodate cases and treat these cases at source. Our rapid response teams, when they are called to respond to cases, be it in the community, at a household, or under a tree, or at a bus terminus, they work at the site to stabilize cases even before a camp is set up. I am mentioning this because there was an article which was on social media somewhere in Chile where they were saying this is how we treat cholera cases under a tree in Zimbabwe. We don't take cholera cases into a hospital because they will contaminate the hospital. So, as I said, that the funerals gatherings are becoming the problems. So you have a village having had a funeral, and you have 10, 20 people with diarrhea coming to report at a health center. We do not take them into the wards, but we have to start stabilizing them outside whilst the cholera treatment center is being put up. And for that case which was reported in Chirezi, actually 2 tents were set up, and there's a spare tent as we speak, which is not filled, but it helped to stabilize the patients before the center was set up. Most important is to know that what kills the cholera is the dehydration, loss of fluids. That's why we say we are setting up oral rehydration points. Somebody has diarrhea, the first thing is give fluid, as much fluid as you can. What kills is that dehydration, loss of fluid in your body, and you start having chemical disturbances within the body, and that is what kills. So I mentioned at the beginning that our case fatality rate is very low. It's because of these early interventions that we do at the place where we have picked or where the cholera cases have been reported. We discourage movement of patients from place to place because all the way that the person is moving, usually they are actually passing their diarrhea, watery diarrhea, the whole place becomes contaminated. Therefore, early management is very, very important. Cholera treatment centers are equipped and resourced with supplies operated by health community workers dedicated specifically to manage cholera cases, while other clinic or hospital services continue to operate and are not disturbed. We are setting up oral rehydration points in the affected communities to offer urgent rehydration to cases in the community before they are transferred to cholera camps. These oral rehydration points are operated by trained community members who will give oral rehydration salts to the affected as they wait to go to a cholera treatment center, and will reduce complications due to rehydration and will save lives. Engagement of other government ministries and departments in the fight against cholera is key and assists in the response using the whole government approach through the setting up of this interministerial committee, which has been discussed by Honorable Minister Masuka. Through this committee, Operation Chenesa Harare has been initiated to rid Harare of the garbage that has been piling up in the streets, communities, and markets. To mitigate against cholera, we advocated for the increase in potable piped water provision at the household level, and we had a dedicated sensor line repaired so that water supply is not interrupted at the moment we have the water. Where there is no council water, alternative sources such as water trucks in the hotspots are being done. As Minister of Health, we had a program to make sure that all our health facilities in the rural areas have clean water, and we have drilled more than 300 bores throughout the country. But during the recent outbreak in Buhera, we drilled 14 bores in Buhera district alone, and the WASH program also drilled 30 bores. So it's one of the most important things that we have to do to provide safe water to the communities. More will be drilled this current financial year. We are not yet very sure how many we are going to be able to drill, but the program is ongoing. Furthermore, we have provided commodities such as jig, aqua tablets, and water guard to strengthen point of use water treatment. The ministry successfully mobilized the release of $12 million equivalent to support procurement of medical supplies, laboratory consumables, food allowances, and trainings at all cholera treatment camps as we respond to this cholera outbreak. We are also working with our partners from WHO, UNICEF, and others for additional support and prioritization of funds towards cholera response. We continue to engage with traditional leaders, religious leaders from various church denominations, community leaders in the affected areas, for them to play a role in cholera prevention and control initiatives. We have reached out to those in Marange specifically because that was the area that was hit hard by cholera in the early stages, and we have made tremendous progress. We appreciate the response that we have received from the traditional leaders as well as the church leaders, especially from the apostolic sect, who have accepted to treat drinking water and also to report to our clinics any cases of diarrhea as early as possible. These include allowing their followers and people under their leadership to report early for treatment, adopt cholera prevention measures that apply to them in their communities, working with Ministry of Health and Child Care officials in a collaborative way. My ministry is working with the Ministry of Information, Publicity and Broadcasting Services to engage the media, including local community radios, in the dissemination of health education messages to the populace, in addition to our teams on the ground giving health education in the district. To that effect, we have benefited slots on radio, TV, and social media platforms. Our ministry has successfully applied for the allocation of oral cholera vaccine from International Coordinating Group on Vaccine Provisions. The decision to allocate 2.3 million vaccines was made on 12 January this year, with the initial 892,286 doses coming into the country by January 28 this year. The vaccination campaign is expected to start from the 29th of January in phased approach to the hotspots. This is because the doses are not enough to cover the whole country, so we've targeted to start with the hotspots and then roll on to the other affected districts. We receive more vaccines. The challenge is that there's a shortage of the vaccine in the world, because cholera is not in Zimbabwe alone, like I said in the beginning. So all other countries that have reported cholera are also getting the same vaccine from the same source. So it's now controlled by WHO to make sure that all the countries can get some. Otherwise, only the rich countries wipe out the vaccine before others get them. We will be targeting hotspot areas, also known as prioritized areas, for multi-sectoral interventions where cases are being reported currently. These areas include targeted districts in most affected provinces of Harare, Manicaland, Masvingo, Midlands, Mashonaland East, Mashonaland West, and Mashonaland Central. Specific provinces districts targeted are Tare Rural, Tare Urban, and Buhera, Hutu, Chirezi, Mwenezi, Mberengwa, Zvishavane, UMP, Kariba, Mazowe, Mbire, Mount Darwin, and Harare suburbs of Wadzana, Glenview, Ubiriro, Mbare, South Park, Highfield, Lenora, and Chitungis. As you can see, some of the suburbs in Harare have been left out because there are very, very few cases for those areas where they got good sanitation conditions. Let me say that currently these are the most affected areas where we will target specific wards that are reported cases. The target age group to receive the vaccines is from 1 year and above. For this campaign, only one dose will be given, as opposed to the usual 2 doses. 1 dose will protect the individual for at least 6 months, as opposed to 2 doses, which is a protection of above 3 years. The vaccine is in liquid form and is administered orally by mouth. Zimbabwe developed a multi-sectoral cholera elimination roadmap, that is 2018 to 2028, that spells out a clear pathway for cholera control and elimination in our country. This roadmap states the need to revamp water and reticulation systems in our cities, provision of adequate water for Harare City, which has grown and increased sanitation coverages in our rural communities. This requires a multi-sectoral approach to eliminate cholera as a public health threat to Zimbabwe. I will not go into details because that has already been explained. In conclusion, let me say that the vaccine is not an end to cholera, but a temporary response which should be complemented with tangible investment in safe water provision, health education on hygiene practices, increase in sanitation coverages, and the elimination of open defecation and removal of solid waste. The streets need to be clean with no dumping and avoidance of food vending and preparation of undesignated areas. This is my presentation. I'm open to any questions. Thank you, Chair.
Okay, that's a mouthful. Enough content for 2 weeks, I think. So we are going to have 3 rounds of 3 questions each, so roughly 9 questions. And let's give each other a chance. If you have asked a question, the next round allow others unless they are not takers. So, Honorable Minister, so that's your people. Questions, please. Name, need your house, and then your question. Yes. From Hutchinson, yeah, gone. Thank you. Female takers? Yes.
Thank you. Areas. Okay, yes. Honorable Minister, what mitigation?
All right. Okay. What's your name?
Okay.
Fatima Msapa. From Sunday, yeah?
Yes.
What's your question?
I would like to find out the mitigation measures that the in areas where
Okay.
Last one in this round.
Thank you very much. My name is Tapazo. My question is directed to Dr. Masuka. That's water situation. Recently, there is a report which came out that 50% of boreholes, particularly in the northern suburbs, remain waste. So, what is your response to Washington? How safe are boreholes as an alternative source of water in urban areas, considering that one of the mitigatory measures you mentioned is that you more boreholes?
That's fine. So this is the first round of questions, but perhaps in order to buttress what the PS Comrade Mangwana has highlighted. You have to mention your name, the media house, and the question. Or perhaps you could direct the question. Say, my question is directed to the Minister of Health and Child Care. I understand this is the perhaps the first session where government meets with the media houses. But I must also appreciate that you all came in numbers to ask and seek clarity on any topical issues. And this is not the first and last. We have more and more sessions where we interact with all media houses. So the first question is coming from Tinashe Matambo from Heart and Soul. The question is where, how, and where. Perhaps I would believe and why. I believe this question is directed to the Minister of Health and Child Care with regards to the management of cholera. Thank you. Over to you, Dr. Mubesho.
Thank you, Chairman. Also, thank you, Tinashe, for that question. But when you say, why did we fail to contain, I think, go back to February 2023. The first case was in Harare, in Delhi. And this is an urban setup. That's the first question you want to say, why do we have cholera in town? And I think it has been mentioned by Honorable Dr. Masuka to say the city of Harare has failed to produce, to provide clean water to the population. In short, cholera is when you have eaten your city. So we've got best sewer contaminating our sources of water. We have bores which are contaminated, which are being used water sources in Harare. And that's the first thing that went wrong. Now, the other cases, if they spread, I'll talk of the second outbreak of cholera, which was in Buhera. That was more related to the religious sect, which had a gathering. In that gathering, there were no good water facilities, sanitation facilities were poor. And people started having diarrhea and cholera in that area after the gathering. But because they did not seek treatment, they don't believe in going to hospital, we had community death. And those relatives handling people who had diarrhea were also getting contaminated and acquiring the same disease from their relatives. And in our tradition, we love going to funerals. You don't go, you are probably suspected that you do something to do with that death. Now we saw a number of cases around that area, and then people who had gone to the funeral, as they went back to their villages, also contaminated their water there, this spread their relatives. We could trace a lot of other cases, including the Chikungunya cases. We could trace them to Buhera. So this is why it spread throughout the country like that. But the reason, your question to say, why did we fail? We failed because we did not have proper water, proper sanitation conditions in the areas. And this is why, after discovering this is a challenge, we have government has taken upon itself to take over issues of the refuse collection, which is Operation Cheneza, to clean up Harare, which is something that was supposed to be done by the city fathers. But when they failed, government has got to come in and assist. So cholera spreads like fire. By the time it has gone to your village, by the time you pick that somebody has got diarrhea, probably 2, 3 others are waiting to show time. So this is why the cholera spread to all centers because of poor hygiene and sanitation conditions that prevail in our center. And we should not be having cholera or diarrhea in urban setup. It should actually be a disease of in the rural areas where we think there's poor sanitation conditions. And the government now has come up strong. We heard the minister saying they are targeting them 25, 35,000 goals throughout the country. So these are now measures that we're putting in place to make sure that we correct. Ministry of Health is just on the receiving end. When you fall sick, we don't care what caused the sickness. We will come in to make sure that you stay alive. So that way we can, but we have now come together and work as a team to make sure that this approach which we are now taking, we address all the causes and make sure we take the corrective measures collectively. I'm sure I've answered you.
Thank you, Dr. Mumbeshwar. Mr. Matamba, I'm sure you are satisfied with the response, but also to complement Dr. Mumbeshwar. The question is, who collects the revenue for refuse collection? Where do you pay for your water bills? And where also do you pay in terms of sewer? You pay to the city or the local. To the second, a question from Fatima from the Sunday Mail about the mitigatory measures that the Ministry of Lands has been able to of health. I thought it relates to both in terms of water provision and also to Ministry of Health in terms of artisanal miners, especially in the Mazoe district, which has become a hotspot. Over to you first, to Minister of Health, then perhaps the Minister of Lands can also then complement in terms of the water and sanitation intervention in the rural district councils. Thank you, Dr. Mangashur.
Thank you, Chairman. Thank you, Fatima, for your question. Artisanal miners are a special group because they don't fit into urban setup, not the typical rural setup. The community that is composed of people from different areas who flood a certain area to try and get whatever mineral. In most cases, like what we're talking about, gold. But if I may recall correctly, the statistics are not wrong. In Mazoe as a district, the cases that were witnessed were also related to criminal, not the areas that had a challenge with artisanal miners was in Chiago. And I actually visited the area personally to see the situation. The challenge that we see with artisanal miners, these are people whom we don't have record. And in areas where they operate, just in the bush, there are no toilets, there are no, there's no borehole to provide clean water, and there are no houses in some cases. These people just sleeping open, like in Chiago, they are just sleeping in the area. And when you try to go into the area, they run away because they think they are going to be arrested. So what we did in Chiago was to talk to the police to say, can you stop your operations of arresting these people so that we can send our people to communicate with them. This is the basic idea. See how we can deal with the water situation of water supply so that we save life. So we had asked them to give us a month, at least a month, where they don't go to try and stop this mining while we talk And I think we now we succeeded because we are not receiving any cases from Tiago. Although we still have some cases coming from Jason Boera and Rangi, but in Tiago, cases are down. What we don't know is, are there cases, are they dying and burying themselves without reporting or what? But I think we will pick it up. So those are some of the interventions that we do. It's very difficult because they are not, there's no village where we say we can go and talk to the leader, somebody, or somebody, nobody controls them. They are just like an individual who do what they have done. Initially, in Chiago, they had been reporting to the clinic. But when the police started arresting them, everything, then they started just saying, we discovered that some of them they don't even have a house. They'll be sleeping in the bed. Some will be sleeping there in the top. But the most important thing, which I think for us, is that we should realize artisanal miners can't mine when it's raining. So it could be another advantage to us now that we are not receiving many from there. Because the rain tends to flood their Makomba, and then it's difficult for them to operate. So they tend to do their operations during the day. So we may think this rain for actually reducing some of the cases because I think those are the main. But we still try to inspire the leaders, the traditional leaders to approach them and give the health education.